give that a go. All right. Well, thank you all for indulging me in your time at the end of the conference. So as we go through the slides, I'll kind of give an explanation about why this is the topic I chose. But I like to utilize quotes in my presentations because they are very impactful. Lucian Leape is a gentleman from years ago, the Institute of Medicine, the IOM report back in '99 about safety events. This was when he was in the Congressional Congress, he was actually testifying about safety in healthcare organizations. So I've found this to be a very poignant quote about the single greatest impediment to error prevention in the medical industry is that workforce members are punished for making mistakes. And so we think about that punitive culture that many of us who are seasoned people have grown up in, that because organizations 30 years ago when I first started my career was if you made a mistake, you were immediately blamed and had finger pointing rather than understanding, why did that happen? So part of what I'm bringing today is sharing about some of the research I did for my master's thesis and how creating a just culture is so important. So the just culture, what is it? It's a concept that's related to systems thinking. So it emphasizes making mistakes are typically a product of a system failure rather than an actual person or persons who are directly involved with intention. So we know that our staff don't intentionally make mistakes because they want to. There are people that do have at-risk or risky behaviors, but for the most part, our environments are truly with people that are motivated internally to provide care to people. So the intention of harm, it is not present. So supporting this culture shift, we have to ask the question, what has gone wrong? And not about who caused that problem. So that's the culture shift, that's the mind, it's not the person. We have to think about it being a true system. So we have to be open and fair. We have to focus on learning to improve. And learning means asking those questions. We have to design safe systems. And we also, again, have to manage behavioral choices. So taking that statement of, yes, we do have people who have risky behaviors or at-risk thoughts. So when we think about that safety versus risk intersection, what is, human error is the unintended mistake. We look at risky behavior, it's individuals choosing to do something either not knowing the risk, policy, procedure, equipment, they haven't been trained on it, or not ascertaining the risk, that they're not thinking in a mindset of the consequence. If I do this, then what will happen? And then reckless behavior is clearly that unjustified conscious disregard, using workarounds for policies or procedures. Sometimes these are embedded in our departmental cultures because techs find, there are too many steps to do my job. I'm being asked to do more with less. I'm going to be able to maintain my productivity but skip steps. So that can be that reckless behavior. So when I did my thesis research, how did I come about picking this particular topic? It's very daunting when I started thinking about safety and culture and healthcare organizations and going, oh my God, like my mind immediately went in 12 different directions. So how do I figure out how to funnel what I was looking for? So when I started thinking about safety, I was reflecting on my own personal past of an employment culture that I had come from, where it was predicated on that punitive response. Errors were, and that type of mindset was highly contagious. So people automatically would literally trounce on a person for making that mistake. I came to a new organization that valued questioning mindsets and creating a learning environment. They were the ones that said to me, and we built our teams on, let's understand where the failure happened. Was it a system? Was it we missed something in a policy or procedure? Does our workflow have a gap and it's causing an individual to create the error? Because if it caused Elizabeth the error and it's truly a system failure, then for you as well, you will fall prey to that. So it's not the person, it's the process. So when I started looking for this idea of, okay, safety, building culture. I went through my typical literature research where you're looking at the broad to the narrow, you look at your fundamental concepts, what are some of the themes in the literature I was finding, and then what was that research gap? Well, I realized after reading, I think I had 40 different articles, there was nothing describing safety in a radiology or radiation therapy environment. Most of it touched on nursing. And I thought, well, I come from radiology. I can't find any literature talking about what prevents us from being able to report safety events. How do we manage them in the environment? So after I put together my literature review matrix and came up with some of the themes that I was seeing, that people had different perceptions of what harm was to a patient. There were behaviors that undermine safety. So if you were in the incivility presentation with John and Tricia, you think about cultures with those bad behaviors that undermine safety. It's the incivility, it's the talking down, it's the condescending comments. Safety culture, some of them had no positive safety culture. They were condescending, degrading. People that made mistakes were punished. We looked at perceived barriers to preventing safety events. So when we look at organizations, they utilize safety event reporting systems to gather data to learn. How do we do better? How is this impacting our patients? How do we ensure that this doesn't happen again? So it may not be a serious safety event. It could be a near miss, those good catches, or it could have prevented harm, which could have been resulting in temporary harm for a patient. So why aren't we reporting? We know things happen in our department every single day. Why aren't we knowing about these things to continue to talk about them and close the gap? And then change management is, if we are getting data on reporting, what are we doing in our departments then to change how we're managing this topic? So when I looked at perceptions of harm, these next couple of slides really talk about some of the things that I pulled away as high points. So healthcare professionals, their perception of harm to patients was judged on physical harm. Physical harm is not the only way you can harm a person. Patient perceptions then were, I am as a patient being harmed physically through discomfort, emotional distress, and inconvenience. Delay of care too. So healthcare professionals possess differing philosophical approaches. We are culturally diverse. We each have our own perception of what harm can be. Healthcare professionals lack an understanding that near misses are harmful to patients, but it's our systems that caught it. But when we don't report those good catches or those near misses, we, one, don't know that the system actually worked well, but how are we continuing to refine and say, we are having too many near misses? Something is still creating that gap. And a fact that event reporting based on individual perceptions of their harm results in the underreporting of safety events. So meaning if my perception of harm is only based on physical, and a patient had emotional distress, I'm not going to report that, because to me, emotional distress isn't harm. So we're missing things. Emotional distress to patients is hugely important. Behaviors undermine safety. So these are the authority gradients. These are our doctors that are nasty, or our colleagues. So authority gradients, the established and or perceived command and decision-making power hierarchy of a group or a team, and it negatively affects the safety voice. So if I'm harsh and brash, and we're talking about safety, and I'm looking to get you to disclose to me your safety concern, you're not going to feel comfortable with me if I'm overbearing and not allowing you an opportunity to talk. So clearly that will shut you down. Authority gradients dominate the theme. When I did that review, I had so much information from these articles about domination and how people were over speaking others. In the incivility, it was about social ostracism, not including you. You reported me, no, you're not part of my circle anymore. When we look at behaviors that result in ineffective communication, so there's conflicts within those interdisciplinary teams. People can't talk together. Elites are ignoring the guidelines. So executives, physicians, senior nursing professionals, could be radiology administrators. They ignore the guidelines, but individuals that speak up are then ignored or disregarded. So there was a great article I had from the Mayo Clinic on cultures that undermine safety. Safety cultures. So organizational culture is tied to organizational values, and it refers how safety is viewed and treated by healthcare professionals. So if safety is important in your organization, safety first will be part of that culture. It will be talked about. It will be in everyday discussions. If you have huddles, guess what? Safety will be talked about first. When there are safety events that happen that affect a department, that will be talked about in those safety huddles so that people are aware of it and will help prevent it and be on the lookout for it. Organizational culture is represented by 3 different levels. You have behaviors, you have values, and basic assumptions. So I reference something called Shine's model, which I'll show you in the next slide, and it will probably look very familiar to you. Voluntary safety event reporting, these rates are causally related to culture. And weak safety cultures are a contributing factor to adverse safety events. So think about that for a second. I don't know of any organization across the country that has mandatory safety event reporting. It's all voluntary. And you can either do it in your organization's system with your name attached to it. Many have rolled out anonymous. And anonymous is because of non-punitive nature of saying we want to learn, but not pointing a finger at blame of your name's tied to it, because then other people will know about it. And you have a poor, toxic, incivil culture, some way, shape, or form, someone's going to know you put that event in, and it will save you. So the anonymous piece. So, but when you have a decrease in the number of voluntary safety event reporting, it signifies that you have a weak safety culture. They're tied together. They're directly proportional. And you're then looking at an increased number of safety events because no one's reporting it. Employee behavior and safety awareness are important drivers of culture and reporting, and structures and actual processes affect your safety behavior. So how your organization puts things into structure and actually rolls out those processes affects how people view safety. So this is Shine's model, and sometimes people know this as the iceberg effect. We talk about it in various things, what you see and what you don't see. So this is the way that we get things done. This is what an organization says that they're doing. We've got strategy, we have goals, we have structures, we've got policies, procedures, shared values, visions. That's your org culture. But then below the surface, that's how things really get done. And these are the norms that we have in our departments. We have shared assumptions. We have our own values, perceptions, unwritten rules, stories. There's feelings. We have norms, how things usually get done, traditions, beliefs. Workarounds should probably be in there as well. So all these things are below the level that nobody knows about, but goes on in our departments every day. Yes. That's where our problems lie. And it's trying to figure out why are the Band-Aids there. And sometimes if we have bad systems and staff bring it to leaders to fix, sometimes with constraints, depending on what the system fix needs to be, is it costly? How quickly can we get this implemented? They lose interest in the department. They become disengaged and like, you know, I tried to share that once before. I don't really care, so I'm just going to do my thing. I'm going to be right in here. Perceived barriers. So why don't, if we're having safety events in our departments and staff are not intentionally trying to harm patients, why don't we know about them? How come we're not understanding where things are at? There's fear of potential litigation, damage to reputation, negative impact to disclosure. So some of that is nursing or physician driven. That impacts a physician very much so with their relationships and the litigation. However, we know, I think it was a year, 2 years ago, a nurse was prosecuted. So clearly the litigation piece can trickle down to nursing and even technologist level. So there's the fear-based thoughts. There's feelings and the beliefs of how you, in your social norms in your departments, how people are going to view you, ostracize you, don't include you. Feel that trust is lacking from your leaders. Fear of being personally accountable. Increased reluctance of frontline staff to communicate their concerns via event reporting. So accountability is a big piece where individuals are trying to share a concern, but no, this isn't mine to truly own, but they're going to be held accountable for it. You know, the paper file, I'm going to put you in, I'm going to write you up and put it in your file. And so that's always being held over their heads of that punitive nature. And then there's a lack of feedback regarding solutions or changes. So that was a big reason why people don't report us. Well, when I do report it, they don't do anything about it and never learn about it. It goes off into a black hole and go, how am I contributing then to this? So disengagement. A few more of the barriers, there's a misunderstanding of what to report. That was an interesting one. Well, I didn't realize that because I did an extra view on the mammogram, I overexpose a patient, but I didn't realize that that's actually a safety event issue. Well, absolutely, because you're overexposing the patient, and you should, what caused you to do that? Fear of rude or confrontational behavior from a colleague. They feel disrespected or ignored when they report events. So some of that clearly, I think, ties real well. John and I were talking yesterday about how some of his content really kind of flowed into mine with that incivility and behaviors. And then people rely heavily on oral reporting, so I don't have to write it. Then it's not documented. This was more prevalent amongst nursing. Again, because I didn't have any radiology or radiation therapy literature to go on, but nurses reported that very heavily. They did not like to document, they would rather orally report. Change management's the last one then. So change management practices increase the opportunities to remove those barriers that prevent more voluntary event reporting. So providing education and training on how to better communicate medical errors to patients. Oh, that's a scary thought. How do we tell a patient we made an error? Now, clearly some of them can be done in a fashion where it's owning up to that. And in the case or the example of the mammography image, it's saying, I apologize, I underexposed that image, I need to repeat it. I apologize. Now, clearly there are some errors that are on a much higher level that involve the risk management and legal teams of your hospitals, and those are those conversations. There's something significant like a serious safety event that either was resulting in permanent damage or death to that patient. So those we would never get involved in, but you're going to certainly be in an RCA and trying to understand, well, what the heck happened? But understanding that we have to share that information with patients. Accountability and transparency are huge. How do we continue to build loyalty with our patients? Top level leaders must engage frontline staff to better understand perceptions. They have to get out. They've got around. They've got to ask questions. What are some of the barriers that you are seeing to do your job safely? Same thing, like broken equipment. Do you not have the tools or the equipment that you need to do? Like, okay, so we now see bariatric patients, but I don't have larger capacity tables. If I have a patient that can't ambulate and they're large, can't lift them, do I have access to a Hoyer lift? So there's various things, and leaders have to be asking those questions, understand what's going on in the front line. Address behaviors that undermine safety. So when there are incivil individuals in the department, whether they be a technologist, an administrator, a physician, someone must step into that role to say, we're going to need to have a crucial conversation. And it's addressing the concern and finding ways with which to change that. Education for physicians sometimes is very important. They can understand professionalism. Leaders must champion a just culture. So establish an infrastructure to analyze events. So when there are safety events, how are they reviewed? How is information shared? Provide feedback. If it was a radiology event, does it only go strictly to the modality that it occurred in? Or do you share it with all of your teams? Because a misadministration of a medication can happen in multimodality departments. Engage frontline staff and physicians, integrate robust IT systems. So some of that has larger implications like the IT piece. But leaders also have to be role models as non-punitive responses. So it's on us when we do have safety events to have a non-punitive approach to that. Make it learning, not blaming. So I did research, sent it out to various respondents through the ASRT, and I asked my questions about what are the perceived barriers that you are experiencing in your departments: radiation, therapy, and diagnostic imaging, so multimodality. What negative stigmas are associated with reporting safety events in your department? So if you were going to submit something, how does that make you feel? What have you experienced in the past? And get an enhanced understanding of how attitudes and perceptions of the respondents correlate to their at-risk or reckless behaviors. So there were some questions I asked about optimism and fatalism, of how do you feel you could safely do things in your department and it not be safety related, like, oh, I always work safe. Going, well, okay. I understand that. However, so this was just some quick data crunching of my cross-sectional descriptive survey. I had 39 questions, and you think immediately, okay, fatigue for survey. 8,900 roughly ASRT members received an anonymous link. 3,200 opened it. I had 452 responses, but of that 452, 109 of those surveys were incomplete. So my total true was 343 members. So it was a small 3.8% response rate. I asked attitudinal questions focused on people's beliefs. So I needed to know your feelings, your understandings. And then perceptual questions that focused on views about how individuals view their safety situations. Again, like, oh yeah, I always work safe. And then if you are a writing research, when you look at some overall information about correlations, Cronbach alpha for my Likert scale questions. So those are the never to always. I had a 0.900 result, which demonstrated high internal reliability of my questions. So these were my domains that I looked at. I wanted to understand about communication openness, non-punitive responses to errors, what were the feedback about reported errors, perceptions of safety, what individuals' motivations for safe behaviors were, what their safety practice was, and then that justification of risk, and then fatalism and optimism. So the next couple slides, I'm probably going to try to go through quickly. It's coming up on the 4 o'clock hour. But I took some graphs from my final document where I crunched all my data and showed questions that I put up, and I kind of highlighted some that brought some attention to me that made me ask some questions of myself and of the data. So staff in communication openness, staff feel free to speak up if they see something negatively affecting patient care. I highlighted the most of the time because I thought, why only most of the time? The most of all of the respondents, the highest percentage there, almost 43% of the respondents, the 343, 43% of people said, yeah, most of the time I speak up. And it caught my attention to say, why don't I have a higher percentage of always? But then I'm looking at some people, I don't feel comfortable at all saying anything. Or sometimes I feel like, yeah, I can speak up. Colleagues in my department are afraid to ask questions when something does not seem right with regard to patient safety. So almost 39% of respondents say, yeah, sometimes. And then this last one, of colleagues in my department feel comfortable to question the decisions or actions of those with more authority when patient safety is a concern. Somewhat comfortable, 42%. So you really get an understanding. There's what I call the authority gradient here, where people don't feel safe speaking up to say anything, even when they know a patient's going to get harmed. Non-punitive responses to error. So these were the 3 questions I asked. And these were I strongly disagree to a strongly agree. They feel like their mistakes are held against them. When a patient safety event's reported, it feels like the person reporting the concern is being written up rather than addressing the actual safety concern. And then staff worry that patient safety mistakes are going to be kept in their file. So on a similar note, but just rephrasing to look at consistency in the response rate. But a lot of people, you know, most of these, the higher percentages for the bottom is in agree. Yeah, they feel like when I report something that's in my file, I need my job. The other one for 28% of people, they feel that the people are being written up versus the safety concern. We had a lot that say, no, I disagree with that. But I also had 29% of people that says, yeah, I agree with that. Feedback about reported safety events. So employees get feedback about what errors happened in their department. So I had, interestingly enough, like 14, almost 20% say no, never or rarely. And so that speaks volumes of we as managers, administrators aren't doing a good job to share with our teams what's happening. Because if it happens to one, it's going to happen to another. And in my department, we discuss methods to prevent safety errors from reoccurring. So again, quite a few respondents, it just makes me concerned that we're not doing a good job. Why do they feel that way? Perceptions of safety. They feel patient safety is never sacrificed to get more work done. That's a huge one. Nope, they're only worried about money. Anytime I say something about safety, it's like, we don't have the money for it. You're not being productive enough. It's only by chance that more serious patient safety related events don't happen in my department on any given day. So by chance, it's luck. There's stuff going on, but it's only luck that they're not more serious. Going, why don't I know about that? Yeah, 19% they agree. Yeah, it's only by luck. These other ones for motivation for safe behavior. In my research paper, I did describe this as the majority of these, 4 of the 5, you had more of these middle of the road, I don't agree or disagree, but social norming. Because no one really felt comfortable, even though it's an anonymous survey of sticking their foot out there and go, oh yes. And I had it in my my notes, exactly what I had. Oh, it's called a social desirability bias. And there is such a thing. And so they were biased because they were uncertain how to really safely answer this question. And then safety practices. Adequate patient safety training in my workplace. So equipment, how to use the safety event reporting system, how to use a buddy system. Management in my workplace are concerned with, not concerned with patient safety. My apology for the typo. It's more profits. And in my current daily work when caring for patient, everybody works safely in my workplace. So these are perceptions. These are how people feel. And then justification for risk. So how safely do people actually work? With specific relation to patient safety, I previously caused a patient safety error because I was not properly trained. A lot of it was strongly disagree, but we did have some people that said, yeah, I made an error. I strongly agree with that. With specific relation to patient safety, I previously caused a safety event or error because I was not aware what I was doing was wrong. I previously caused a patient safety error event because I needed to complete tasks quickly. I see a lot of people mentioning that is the increased volume of work that they're being asked to do because perhaps there's an influx of patients, you're short-staffed, and so the burden is distributed on less people, but they need to do more. And then an individual, I've previously caused a patient safety error event because the right equipment or supplies were not provided or was not working. And then these last two are about fatalism and optimism. So if I worried about patient safety all the time, I would never get my job done. Patient safety related accidents will happen no matter what I do. And I'm unable to do anything to improve patient safety in my workplace. So that's the fatalism, like I can't impact it at all. I just do my job. And optimism, I don't encounter anything dangerous for patient safety, you know, during my workday at all, which could be true, but as we know, the acuity of our patients, anything at any moment can happen. And it's not likely that I have a patient safety related error event because I'm a careful person. So that's a perception, that's a belief. Okay. Yeah. Oh no, I'm safe, nothing's gonna happen. So what do we have to do is eliminate opportunities for workers to choose risk, reduce that risk. Don't allow those things to happen. So I'm going to go through the next several slides of just kind of things with which us as administrators, managers, executives can do to help build a different safety perspective and are building that culture, which will then reduce safety events, but it increases reporting to really understand where are the gaps and how do we need to change things. So HROs, these are the pillars for HRO is preoccupation with failure. So you know things are going to fail. Let's focus on that. Sensitivity to operations, deference to expertise, respect for people, commitment to resilience, constancy for purpose, and reluctance to simplify. So if we think we understand the reason why it happens, if we're trying to simplify it, that should be a key red flag for you there because it shouldn't be simplified. You should do, if some of us are lean, have gone through process improvement, ask the 5 whys. If you're trying to simplify and someone says that, do a 5 whys because you're going to then dig to the bottom of actually why that happened. Understanding human factors. So this is, there is a body of work around human factors, and many organizations have people in their performance improvement departments that strictly work and understand human factors and how they play a part in safety. So it's a classification system that identifies errors based on a skill, a rule, or a knowledge. So anytime we do a task, it can be one of these items and how we make decisions. Is it knowledge based? So if you haven't been trained on something, I'm going to use my knowledge base. That's where an error could potentially happen. Emphasize the interactions between humans and the surrounding environments. So socio-technical systems. The goal is to reduce human error, increase productivity by eliminating waste. We all know that lean process. And then through that, enhancing the safety and usability. And these are vital because errors, no matter our role, can have an impact on our patients. So needing to improve safety in the process to reduce error and apply simple tools to identify, resolve, and escalate issues. That's a very high level overview of that. But there's a true discipline on human factors. Error proofing, how to improve processes. So we want to prevent error when possible by eliminating, replacing, or facilitating tasks. And if error cannot be prevented, is increase the likelihood of detecting them. So that's the near miss. That's we want to limit the consequence of the error. Through psychological safety. So this isn't something inherent in teams at all. It's a relationship building with individuals and within a team to create a sense where you feel comfortable to say something. And if anyone is familiar with Amy Edmondson, she's a lady that coined the term team psychological safety, but it's this shared belief that's held by members of a team that it's okay to take risks. And those risks are to express your ideas and your concerns. But at the same time, you can speak up with questions and admit mistakes. And it's all without a fear of negative consequence. So it's this felt permission to have candor. It's that civil, crucial conversation. And leaders can build this by creating the right climate, the mindset, and behaviors. So research finds that positive team climate in which team members value one another's contributions. We care about one another's well-being because these are emotions, these are feelings and beliefs. And if we recognize that and saying, thank you for sharing that. I know that was hard for you, but I appreciate your thought. And have input into how teams carry out their work. It's the most important driver of team psychological safety. So it's thanking people for contributing and figuring out what happened rather than who did it. So these are, this is a great book, The 4 Stages of Psychological Safety by Tim Clark. These are the things that have to be in an environment for psychological safety to be present and to be built. People have to be comfortable with giving and receiving feedback. They have to feel comfortable being able to raise concerns and issues. It's okay to disagree. Professionally, we should be doing that. We should be asking someone to step up and say, I'm not agreeing in your thought. Let's discuss that further. Ask for clarification. Ask difficult questions. Ask for help. Provide solutions to problems and admit errors. We also need to utilize our emotional intelligence a little bit better. Intelligent leaders are aware of their impacts on others. So how we interact, what I say, my body language, microaggressions. Emotionally intelligent leaders strategically use their emotions to help them achieve outcomes. Leaders are both cognitively and emotionally empathic. Leaders pay attention to both what's said and what's not said. We maintain a positive team and climate. We have a rich emotional vocabulary, and we are open to developing our own EI skills. So we're not perfect. If we make a mistake, own up to it and say, I apologize. The intent of my comment was not how you perceive that. That's my error. I did not mean to be rude or demeaning. That gives you accountability. You step back and go, can I try that again? And you'll be, yes, please, I would like that. This is a wonderful tool to help with the conversations in assessing error and determining, was this truly just a mistake, or are we dealing with a risky individual who is choosing to forego policy and procedure? This was put out, Pearson, if I can read that fine print very, James Reason, and this is called a culpability tree model. Joint Commission uses this, and my organization that I was at previously to UTMB adopted this as well. And this is used when safety events are reported, and all of the time it's going to involve an individual. It's going through these these individual questions to determine what actually may have caused the error. So this first one is called the deliberate harm test. You're really assessing, were the actions of this individual intentional? So do we really have a risky behavior? Is there something here where it could be, although it assesses adverse events, is this individual fit to work? People understand you're fit. Okay, do we have a psychological issue going on? Is there a drug abuse, something that caused that intentional harm? So if that's not it, we go on to the next one. sorry, this is the incapacity test where we're looking at substance abuse or mental health concerns. Then you go to the foresight test. So did the individual depart from the agreed protocols or safe procedures? So this is the column where ask questions. Were there protocols and safe procedures available, workable, intelligent, correct, and en route for use? Meaning, were there policies and procedures established for your department for this exam, this process, and answering the question, did this person not know about it because they were newly onboarded, so there's an opportunity for education and training, or what is this a repeat issue? Or yes, they've already been counseled, they've been given the policy to read, they have been trained and educated, now they are choosing to deviate, so that's an at-risk behavior. And then we go to the substitution test. So would another individual coming from the same professional group possessing comparable qualifications and experience behave in the same way in a similar circumstance? So it allows you to go through with unbiased, so an individual in the department, so Elizabeth and I don't get along, and Elizabeth caused an error, and I as her manager am going to sit down and go, she may feel that I am being punitive and biased, but if you use a tool like this is an unbiased approach. And there's multiple people that are included in this. It's not just the manager and the individual. You could have your safety representative, you could have another administrator, and it would be inviting the individual in and having your own debrief and going through, tell us what happened, ask some clarifying questions, but make the space safe for the individual to share their side of the story and not be punitive.
What I like to do when I'm doing the I like to tell the person who's involved in this, please help me to understand what happened. I am now closing this curtain. I'm behind the curtain. I wasn't there. Paint a picture.
Yes, we had at my past organization, she was a nurse, but she's not a technologist and did not understand the intricacies of some of our procedures. So that was truly her saying, you need to educate me on what it was that you're doing, because I don't know. And in order to understand how we fix this and prevent it from happening to another patient and another one of your colleagues, I need you to be open, and I'm going to ask you questions, and it's, let's have a dialogue about this. Those can be hard, but this sets the stage for creating that psychological safety to understand what happened and trying to understand. Again, we have people that aren't intentionally trying to harm patients. They don't want to do it again either. So if we do the right thing and train them and go, I know exactly what happened. We will get what you need. We will get you the equipment. We will have someone available, whatever the case may be. This has wonderful outcomes, but it also establishes trust with your employees, and it then creates better loyalty as well. But then guess what? Word of mouth is the best marketing. They're going to go around to the rest of the department and start slowly sharing the message of saying, you know what? So-and-so I had a great experience. I'm not fearful of my job. I didn't get written up. They truly want to learn what happened, and they want to make sure I never do it again. Then that next person's going to be like, okay, I'll give it a try. And that's that culture change. It's the shift. It takes a long time, but one person can be the catalyst to that change. It only takes one. Yes.
What my department did as additional step to that, what I would do is I would ask permission from the person that the event happened to, if we could utilize this as a case study. And, not next meeting, we did put meetings down, so then we would present it to the entire department with no names, and it kind of was this empowering to the person. I never had negative feedback after that, so that way we didn't repeat the same behaviors or errors, and shared exactly what happened with details. It helped us.
Yes.
And I had one of my staff members say, because he knew the process, he said, I want to tell my story, so it doesn't happen to anybody else.
Yes. Yeah. But I do feel that there are people in the department that want to do that want to share the story, but give their perspective also. Because guess what? Once that person, it's not a leader up there sharing the story, because everyone's like, oh man, who did that? It's this person is showing vulnerability, and man, that speaks volumes. Because guess what? If I'm vulnerable and someone else did something and we're like, hey, can I ask for your help on something? And you start to change that culture. Like, absolutely, I got your back. I've got your back on this. Policy implementation. This is always easier said than done, but my organization created an error assessment policy and wrote it up and used that error, the reason culpability tree for how they would talk about safety events. So they made it part of the departmental policy so employees understood, here's how we make our decisions. Here's the discussion that we have. So it's not this secretive thing where you walk out from a radiology administrator's office and you know, the employees white as a sheet and they're like, oh my God, like what happened in there? This is open, it's transparent. This is how we make, this is the information we need. Stop the line for safety policy. It is to protect patients, but it empowers your staff to say, I see something that I'm not comfortable with right now. And it empowers them to say, I'm unable to proceed and I have to stop until I have my questions or concerns addressed. Because many times staff feel, well, I felt I was doing this and I was being forced to do it because the radiologist was in the room, and that dominant behavior and saying, I didn't feel comfortable to say no. Like he would get me fired. This is empowering people to say, I need you to speak up and say that. And if you do that, I, as your administrator, I'm saying, I support this. I need you to save this. I need you to embrace the awkwardness, lean into it because you know you're doing the right thing. And when people do that and they feel the response they get from it, again, it becomes contagious. Other people will be like, I'm doing it, because they don't want to be put in a position of not speaking up. Because guess what, when you have a debrief and go asking these clarifying questions and they said, well, I know it wasn't right for me to do. Did you say something? No, I didn't feel comfortable speaking up because so-and-so is in the room with me. So it's a requirement. I need you to speak up. And then, you know, having a just and fair culture policy. So it's a high level statement of values and commitments of an organization to treat healthcare workers fairly when a patient is harmed or nearly harmed by a healthcare delivery. So it's a statement. We will be behind you to support you on this, and we will debrief and understand how to justly and fairly manage these events. So things to start, you could teach theories. What are never events? What are human factors? What are leading and lagging indicators? Share research. So if you're seeing something out there that would be valuable to people, is share that with your team. Some of your team members may value reading articles, or if you're in a department, do a quick snippet of some data. Focus on good catches, like what is that? Have people share their safety stories. Get them to talk about safety. Make it normal to talk about these things. Who's a champion in your department? That during your huddles or meetings, you have your safety champion. They're up there and they're sharing information. They're engaging their team members rather than just an administrator talking. Daily rounding, asking specifically, what safety concerns are you seeing in your work today? Have to ask that specific question, not what's going on, is there anything I can do for you? That's way too open-ended. But if you focus and make safety important, then you speak about it and say, are you having any safety concerns today? And like, absolutely, I'm glad you asked because I totally forgot about it. Practice, use some safety scenarios to practice that error assessment tool. Get people comfortable with how it works so that when they're in situations or they're learning, or perhaps you're mentoring people, they're on board with that. Implement a huddle TV. So my past organization in the break rooms had a TV, and the content that was shared either in department meetings, safety issues, any other time, real-time communications were in a PowerPoint presentation that just constantly rolled through on the TV. So the various shifts of workers that were in the department were seeing the same content. And then focused communications. So if people are having issues in the departments with communication using iPass, which was a new nursing one, or SBAR handoffs. And then is there a way to train your team on Lean or Six Sigma stuff? Some organizations are large and have performance improvement departments and can come out and train staff on getting their white belt. And then these were some comments from some of my respondents, and I thought they were very profound. One said, I would feel more comfortable bringing up concerns if I felt my management team cared at all about our patients. They just see dollar signs. We can voice our concerns about patient safety, but management's answer is always, well, we'll look into it, and nothing ever changes. If you verbalize something, you are chastised for rocking the boat. And then the other is, in general, some people hesitate to report safety events because they don't want to be retaliated against by a colleague, a doctor, or a boss. At times when a safety report is made, people feel that it won't do any good because no changes will be made. Most of the employees feel the hospital cares more about money than patient safety. Unrealistic clinical rules, protocols, and expectations are implemented by non-clinical people. Employers want you to do more with less, and that's a huge safety issue, and it's a disaster in the making. So my final quote from Benjamin Franklin is, well, if you tell me, I'm going to forget. If you show me, I might remember. But if you involve me, I will understand. And so some of that education and the training and the questioning and being transparent and in the moment is sharing with people, you know, if you want to have safety culture change, you have to teach people what it means. And understanding some of that content of human factors makes a whole lot more sense for people, and they all learn differently. Some need to read, some need to listen, and others are more visual. But involve people in this. That's a catalyst for making that change.